Hello, thank you for being here. My name is Muyang Kim, working at GSI Clinic in Seoul, Korea. There is no financial interest in presenting this data. This is an overview. This presentation will focus on the one-year result of the more than 10,000 cases of biotech Fakig IOL experiences. Please allow me to introduce us first. And GSI Clinic is one of the famous refractive centers in Korea. Our 7 doctors have been performing toric Optiflex or the ICL and even IPCL surgery longer than 20 years. But recently we started the biotech Fakig IOL surgery first in Korea. And last year we reached 1,000 cases and 1,500 now. Among YouTube channels, the speaking in Korean, my site to support patient education as an eye doctor has the largest number of subscribers. Now let's move on to main topic. As you know, patient satisfaction after lens implantation surgery is tightly related to the remaining astigmatism. Biotech Fakig IOL has some characteristics: larger aspheric optic, more rigid plate tape haptic, and considerably high bolt structure. So it is very useful to stabilize IOL, not to rotate inside the chamber after implantation, and consequently stabilize cylindrical refraction after surgery. And we can expect the cataract progression might be prevented because this IOL does not touch the lens anterior surface, and soft gel-wise material is easy to be inserted into an injector and easy to be manipulated inside the chamber, even in narrow anterior chamber space. So it will not touch and hurt endocellular cells. In next few slides, I will show you the study design. We included 782 eyes of 386 patients. Astigmatic cases more than 1 diopter were treated using toric IOL. Most patients are highly myopic, not suitable for laser treatment, and over 21 years old, and having enough endocellular cells. Patients with narrow anterior chamber and glaucoma or uveitis history were excluded. Pre-op data is mentioned in table. Preoperative spherical equivalent of is minus 8.35 diopter and minus 2.69 diopter astigmatism. And maximum spherical equivalent was minus 17 diopter and minus 4.75 diopter astigmatism. Basically, biotech toric IOL can support only up to 3.5 diopter astigmatism. So many of our high astigmatic cases cannot be easily cured with biotech toric IOL. But because of undercorrection of astigmatism 1 diopter with adding just 1/2 diopter spherical equivalent overall, is definitely safer way to prevent postoperative hyperopia. So biotech toric IOL is enough to cover almost all cases of our study. Only 2 candidates over 6 diopter astigmatism were treated with another lens. Before and after surgery, refractive errors, both intraocular pressure and endocellular cell numbers were measured. Yes, and especially for toric candidates, IOL rotation was carefully checked just 1 day after surgery. Very few cases showing more than 10-degree difference from the target was corrected promptly. Spherical equivalent was immediately changed to 0.21 diopter after surgery and improved up to 0.03 diopter at 1 year. So we can say, concerning the accuracy, yes, it is reliable. This graph shows significant improvement of postoperative UDVA against preoperative CDVA in most of the patients at the end of 1 year. Postoperative bolt remains stable within range. There is no explantation is required. and there is no significant decrease at 1 year. Regarding intraocular pressure, it remains stable. During 1 week after surgery, we prescribed Elazop twice, that's enough. But besides, in some cases, IOP jumped up due to the obstruction of central optic hole with inflammatory membrane. Yeah, that is maybe happened. And sometimes by using YAG laser, IOP was stabilized along with the use of anti-inflammatory agent. For severe inflammatory cases, intravitreal antibiotics was needed, but all inflammatory cases were cured successfully and no IOL was removed. Endocellular cell numbers, yeah, there is no significant change, and at the 1 year, only 1.7% of cell loss was found. Yes, and we inserted phakic toric IOL for 430 cases. Because we studied toric cases 6 months later than non-toric version, so these patients were followed up 6 months for about the refraction, both IOP and rotational stability. Spherical refraction, yes. Here is about a result of toric IOL. It shows a very good spherical refraction correction, same as the non-toric version. And if you want to get a suitable IOL data for biotech toric IOL, you need keratometry, WTW value, and internal edge depth, and phakimetry also. But practically, it's very simple. If you get connected to optiflexcalculators.com, you can easily get the most appropriate data. Well-designed biotech calculators program can easily support IOL data. It's not easy. And residual spherical refraction at 6 months is just 0.19 diopter. This graph shows cylindrical refraction. Yeah, that result was perfect. Considering amount of astigmatism before surgery is about 2.69 diopter. So yeah, result is wonderful, I think. But within 1 week, the result is not fully achieved because of wound healing process, but it tends to reduce to expecting value, and at 6 months, post-operative residual spherical refraction is just 0.36 diopter, which was all accepted by the patient. And there is no difference between superior and temporal incision site. Originally, company recommended temporal incision, but however, most young Korean patients commonly with the rule, so I usually use superior incision. This graph shows significant improvement of post-operative UDVA compared to preoperative CDVA at 6 months. And more than 93% of patients achieved UDVA 2025. Post-operative bolt, yes, stable, remains stable. And endocellular cell damage is not clinically significant. At 6 months, only 2.12% loss was found. As I explained before in the introduction, the biotech phakic toric IOL have some characteristics: high bolting angle and more rigid junctional structure between optic and haptic. So it is very easily stabilized inside the anterior chamber, and there is very few cases to be manipulated to the target. I mean, among the 430 cases, only 2 cases show more than 10-degree distance from the target. Here is a brief surgery video. I prefer to superior incision. Through it, yes, compared to another lenses, we can gently push out slowly. Easy to be inserted and rotate smoothly. because the haptic edge is more rigid than another ICL, so it is easy to be inserted. I'd like to wrap up the presentation with short summary. Biotech Phakic IOL is really effective for high myopia and shows excellent stability without rotation. But I think more investigation over a lot of years should be followed, and I have a plan to compare with ICL next time. Thank you for your attention.